Great. Well, what a fantastic welcome. Thank you very much indeed. My name is Monty Mython. I'm Editor-in-Chief of Top Med Talk, and I'm delighted to be hosting this live event from here, the Sheraton in Raleigh, in beautiful North Carolina, where I used to live, by the way, if anyone's listening. Hi, Mum. We're having a dinner symposium here tonight. We've got a fantastic audience, a room full of hundreds of enthusiastic people. Hey, folks, you having a good time? So this is part of a very special event. So lots of us around the world are very interested in enhanced recovery after surgery, but this is an enhanced recovery cardiac event. So enhanced recovery after cardiac surgery. And this is a 2-day symposium. It starts tonight and it goes on through tomorrow. And it's looking at ERAS Cardiac, and it's a Center of Excellence Training Conference. And that Center for Excellence in Cardiac ERAS, the first one in the United States of America, nay, the first one in the world, I believe, to be given this designation, is just down the road here at Wake Med. So let's give it up for Wake Med. Now, I'm joined by my co-host, Desiree Chappell. Desiree, how are you this evening?
I'm good, Monty.
Good. And you're going to be here, you're looking after not only the people in the room from the questions, but you're looking after the rest of the world. Tell us, how's that going to happen?
I am. So this is a live event, and we are broadcasting out to listeners and viewers from around the world. So hello, everyone. I hope you guys are having a fabulous night, and they're taking very good care of you. Thank you so much for joining us. And tonight's going to be a really interactive night, isn't it, Monty?
It is very interactive. So not only are we hoping you get those questions coming around from the world, we're also hoping that you will ask questions in the room, but also make comments. And I've been talking to our guests who are going to come up here and entertain us, and they're going to be pointing fingers at people and saying, come on, you know more about this than I do. What have you got to say about it? So be prepared.
Right, but for all of our guests at home,
yep.
Not actually at home, but for wherever you are listening and watching, please join us by Slido.com. That's our online Q&A platform.
Can we get Slido up for a second, guys, on the screen? Have a look. There it is. Yeah. So www.slido.com. And then the code you put in is Edwards, our generous sponsors for tonight and tomorrow. Edwards Life Sciences, Edwards, EDWRADS 1919. And we'll come back to that repeatedly to explain it. So we're going to start, this is in 2 sections tonight. We're going to start with 2 short lectures and a discussion. And it's a very special moment. I think we should stand for this, actually. Because relatively recently formed was ERAS, Cardiac Surgery, Enhanced Recovery After Cardiac Surgery Society. And we have with us one of the advisory board members and the inaugural president. Gentlemen, if you'd like to come and join us on the stage. Thank you. Dan, great to see you. Kevin, great to see you. Please come and take a seat. We have your mug shots up there for everyone to look at, and I'm going to ask you to both introduce yourself, starting with you, Kevin, as an advisory board member of this thing called ERAS Cardiac.
Thank you, Monty. Kevin Lobdell. I'm from Charlotte, North Carolina. I've been involved in quality efforts for about the last 15 years, and Dan and I got to know each other in the last few years through the enhanced recovery efforts.
And Dan, where are you from?
Oh, I'm from Springfield, Massachusetts. I'm a Massachusetts native. I trained at Brigham and Women's Hospital, and I'm a cardiac surgeon. And I've now started to focus over the last, I would say, 5+ years more on perioperative medicine, and help to get this group of very engaged experts together and work to standardize best practice.
Now, you've both prepared a few words for us, supported by a few slides. So I'm going to hand over the magic device here. I know who's going first because you give me limited ideas. Oh, here we go. We can see what's happening there.
I believe I'm first. So
the president.
I'm going to stand. So thank you all for coming. So I'm going to give you a brief overview of ERAS and how it relates to cardiac surgery. Coincidentally, really the origins of all ERAS, not just in cardiac, were really fast-track surgery. And coincidentally, fast-track surgery was actually invented by my father, who's seen here on his favorite slide, which is where we got to be standing next to a billboard they put up in our town, because he's a cardiac surgeon also. And I'm one of the few heart surgeons in the world who actually got to operate with his father, which was kind of fun. But that really was the origin. But Fast track and ERAS really they are not that similar. They diverge in that fast track was all about getting patients out of the hospital quicker. It was all about speed. And it was originally put out in 1994, and here was the original article. And ERAS is different. ERAS is not necessarily about speed. It's about value. It's about improving outcomes. It's about standardizing best practice and improving quality. So it's sort of a natural development from it. This slide is really the one most important slide that I put in every presentation, and I remind myself, and we're going to talk about it a lot, and if you're going to learn one thing tonight, it's that we are experts in the operating room. Anesthesia, cardiac surgery, we go to our meetings, we spend a lot of time discussing how to fix valves, how to sew on grafts, what valve to put in, how to maintain correct temperatures and bypass circuits and prevent bleeding. But it turns out that 80% of preventable mortality after cardiac surgery occurs outside of the operating room. So we spend 99% of our time at our relative anesthesia, critical care, and cardiac surgery meetings discussing the operating room section and skip the 80%, which actually may cause preventable morbidity and mortality. And that does also include the pre-op portion, which, as you can see from this slide, makes up 35%. And that would be something like an inadequately prepared patient for surgery. So what is enhanced recovery? Most of you in this room probably know. Most of you people who are watching probably have some sense, otherwise you wouldn't tune in, but it's a research-based approach using selected pre, intra, and post-operative interventions in concert to optimize outcomes and the patient experience. There's standard practice in Europe. Europe's way ahead of the North America in ERAS. You can't have surgery in Europe, at least in non-cardiac surgery, without being in an ERAS program. Usually there are 20 or so different components that make it up. And they've all been demonstrated to have resulted in significant reductions in length of stay, blood loss, time to ambulation, complications, and increase in patient satisfaction around pain. What caught my eye and a bunch of the board members' eyes were that about 2.5 years ago, we noticed that there were ERAS societies in every subspecialty, and except for cardiac. There was a thoracic, but there was no cardiac. And we came up with this novel idea, well, why don't we do it? Why don't we see if we can get together, read the entire literature that relates to this, and see how does it pertain to cardiac surgery? And people said, you can't do ERAS with cardiac because it's too complicated. You have that pump and all the blood loss and bleeding, and it's not simple, but it turns out you can do a lot of the ERAS components in cardiac. So we developed a society with a straightforward mission to optimize perioperative care in cardiac surgical patients through collaborative discovery, analysis, expert consensus, and then the subsequent dissemination of best practices. And this is just a basic overview. We'll be discussing really more of this in detail tomorrow, drilling down into the basic components. But these are similar in all ERAS protocols, really. We have some specific ones in cardiac, but I would say in general, the pre, intra, and post-operative components are somewhat similar. As we pointed out a little bit earlier, we have really only one dedicated center of excellence in cardiac per se right now, and that is WakeMed. And they became a center of excellence because not only did they implement these processes in a defined manner, they audited their results and then published them and showed excellent, outstanding results. And that's really what defines a teacher. And this is the perfect example of why they're a center of excellence, because now they're teaching the teachers. And this group, these people in this room and these people watching this webcast, we are going to be the next centers of excellence and we'll be the next teachers. So the teachers are teaching us to contribute. The best part about our society was that we finally got our consensus document published in JAMA Surgery. It's only been out for a month or so. Doesn't go into print until August, but already has 45,000 downloads. I urge you to take a look at it, and it's really a good short outline, at least, of the major factors that make up an ERAS program. This slide I like. I'm just about done speaking, but I do like the fact that we're a little disruptive because I don't want to bore people. I think if you're going to speak, everybody agrees, yes, you should try to use opioid-sparing analgesia and decrease opioids. That's not disruptive. Maybe how you do it is disruptive, but nobody's going to argue with you. But some of these other things we came up with or we're thinking about are a little bit disruptive, at least to the average cardiac surgeon. Some of the things we came up with are that elective patients probably should be optimized. They should be put off for 3 to 4 weeks of prehabilitation prior to surgery. Those are patients who have malnutrition, preoperative anemia, frailty, glucoses that are out of control, or smoking or drinking hazardous alcohol use. You probably should do your best to postpone that surgery. The problem is cardiac surgeons say, well, gee, now I'm nervous because the patient won't come back, or they'll go across town, or they want their surgery tomorrow. But in a perfect world, the data suggests that these patients should be postponed slightly. We need to end our pre-op dietary restrictions. NPO at midnight is gone. We need a 4-hour clear liquid diet restriction. Wire cerclage versus rigid sternal fixation. There's a lot of data developing. There are 2 good randomized control studies that show that rigid sternal fixation probably is better, especially in select high-risk patients. Ambulation restrictions probably need to be liberalized a little bit, and chest tube management strategies. These are just some of our broad ones. I'm going to drill into more of these tomorrow, but you probably can reduce AKI using some novel techniques that I'm going to talk about tomorrow. And as Monty absolutely will agree with, perioperative medicine, which obviously includes the preoperative period, is probably a subspecialty under its own. It needs to be more focused at all of our international meetings of all our societies, and it may be more important at this point to outcomes than the intraoperative component of the CT surgery. So what's ERAS about? It's about patient-centered value. Value is actually, it's the PRO, it's the patient-reported outcome. It's not the results you get from your STS database. It's what the patient perceives as their outcome, how they did from the surgery, divided by the cost. So that's value, and that's what we're trying to improve. And our core principles are to standardize these best practices by reducing pain, length of stay, cost, and readmissions. And all I can point out is thank you all for coming here. It's a multidisciplinary effort. These are just some pictures from my team. You can't do it without the help of your pharmacists, your nurses, your advanced practitioners. The surgeons have to be on board. We have intensivists, cardiologists. Everybody has to do it together. Otherwise, it'll never happen. And I would just like to put a little pitch out to our next multidisciplinary meeting, which will be in September 26th through 28th in Baltimore. It's co-sponsored by the STS. And we're going to have a full day of cardiac ERAS on the September 26th. So if you're interested in this type of stuff, that is our next meeting. And now I would like to sort of pass the baton on to